The topic we are going to discuss today is toxocariasis, and it's going to be interesting. Toxocariasis is caused by infestation with a common intestinal ascarid or a roundworm of dogs called Toxocara canis. Puppies are more commonly infected than adult dogs and are more likely to spread the organism. To our shock and horror, the feline variant Toxocariasis may also be causative. Here in this histopathological picture, we can see clearly the ascarid surrounded by blue lymphocytic infiltration. Now, young children are at particular risk from the soil of parks and playgrounds. Human infestation usually occurs by ingestion of soil or food contaminated with ova, which are shed or excreted in canine feces here, and especially by puppies, as I have already mentioned. So this puppy here, cute little puppy, is responsible for shedding the ova in the soil, and this is then ingested either by other uh, animals or through the soil or contamination of food. It is ingested by humans, and once they're ingested, the ova develop into larvae, and as you can see here, they enter different tissues. They enter the liver, they enter the lungs and skin, of course, brain, very important, and eyes, of course, and resulting in inflammation. Patients usually present with asymptomatic infestation. That is a very common presentation, but there is also visceral toxocariasis, also called visceral larva migrans. It is a systemic infection of variable severity that usually occurs in a child of 2 to 7 years of age. Fever, abdominal pain, pneumonitis, lymphadenopathy, hepatomegaly, and myocarditis are some of the possible features. We have to keep in mind that visceral larva migrans, it moves to liver, lungs, hence the pneumonitis, abdominal pain, and hepatomegaly. And so spontaneous recovery is usual. Death is very rare and usually occurs in individuals hypersensitive to parasitic antigens. Covert toxocariasis is associated with mild systemic symptoms. Now, the important part, which is very much relevant to our subject, is ocular toxocariasis, or called ocular larva migrans. It generally occurs independent of visceral larva migrans and is associated with a lower parasitic load. It is typically unilateral, and in around two-thirds causes some degree of permanent visual impairment can occur. In contrast to visceral toxocariasis, it tends to occur in older children and adults. Now, it presents in different forms. First of them is chronic endophthalmitis, which typically presents with leukocoria, strabismus, floaters on unilateral visual loss. Features may include anterior uveitis um, or unilateral visual loss. Features may include anterior uveitis, vitritis, chorioretinitis, papillitis, and a fundus granuloma. A dense grayish-white exudate similar to the snow banking seen in pars planitis may involve the peripheral retina and pars plana. Now, complications leading to a visual outcome which is poor include tractional RD or ciliary body detachment with hypotony leading to phthisis bulbi. Posterior pole or peripheral granuloma without inflammation is another presentation. Uh, so it classically occurs in older children. This is seen in a picture here. There is a granuloma here in the with a vitreous band, and then there is in the next picture there is a peripheral granuloma with a vitreous band extending to the disc. The relationship can be seen here. And in the third picture, there is wet peripheral granuloma with underlying chorioretinal scarring. All can be seen here. So, the patient usually presents with unilateral impaired vision, or as an incidental it can be an incidental finding. A 1 or 2 disc diameter sized yellow-white granuloma is present, as it is seen in the picture, and in the posterior fundus or periphery. Vitreoretinal fraction may lead to complications due to macular distortion or retinal detachment. Third presentation is with the chorioretinal scar formation as seen in the picture here. There are multiple scar formations. And the last but not the least is the diffuse unilateral subacute neuroretinitis. This I will discuss later in another video. I will link it in the description later on, because this is a whole topic on its own. We have to differentiate it with from retinoblastoma, because some of the children they present with the white reflex as seen here, but on dilated fundus examination the diagnosis becomes clear. Now, as I have already mentioned, distinguish it from retinoblastoma. Other helminthic organism can also give similar clinical manifestations. So what do we have to do? First of all, full blood count. Eosinophilia is something that may be present particularly in visceral larva migrants and can become chronic. Hyper gamma globulinemia, especially IgE. And serology includes antibody to toxocariasis are detectable in only about 50% of ocular cases. Positivity is common in the general population, which is 14% of all in the USA. Ultrasonography may be useful if the vitreous is hazy. Aqueous or vitreous sampling for eosinophilia in antibody detection and PCR. Biopsy of a granuloma of the skin and or elsewhere for larvae is sometimes possible. Now for the treatment, first of all, prevention. By good hygiene practices and deworming of pets. Most important thing. Then comes our favorite drug, that is steroids. Topical, regional, and systemic may be considered. Anthelmintic agents such as mebendazole, thiabendazole can be considered in ocular toxocariasis, remembering that worm death may promote inflammation. And in the end, vitrectomy for safety. So this concludes our topic of toxocara. also called toxocariasis or visceral larva migrans or ocular larva migrans. And if most of the content is taken from the 9th edition of Kansky, and if you would like to add anything or like me to add anything in the subject, please mention it in the comments, like and subscribe. Thank you all.